be zirconia versus titanium, whatever. There are enough topics. So with this preamble, let me call upon Professor Dr. STEFAN IHDE. He would like to make some opening remarks before we start the meeting. Dr. IHDE. Just go.
So thank you very much for the invitation, for your words. Thank you very much for everybody coming, and thanks for Inspire Dental to arrange this, to invite everybody. I think the first man, I mean, we mentioned Lenny Linko, we mentioned Carl Misch. The first man we have to mention here is Dr. Vivek Gauhar, because he's the driving force behind strategic implantology in your country. He sometimes is also a driving force behind me, because he always, challenges me, wants me to, contribute more, to, to work harder. So we are a very good team. Thank you very much. For those who don't know me, my name is STEFAN IHDE. I was born 1962 in West Germany. I was brought up in that country, and I studied 1982 to 1987 dentistry in Würzburg, Germany. And I wrote my doctoral thesis later also at this university. I emigrated to Switzerland in 1989 for various reasons. Main reason being the healthcare system in Germany being, let's say, socialistic, if not communistic. So I didn't want to work in this system. I was lucky to get out and to work for many years in Switzerland and to research in Switzerland. I did this there until the year 2010. During the last years, I have spent more and more time for teaching. This means individual teaching, courses, congress, lectures, and so on. Also, I wrote a number of textbooks, many articles, also articles in SCSI journals or impact factor journals. I want to mention this here right away. Because there's some doubt, obviously, that there is a science behind what we are doing, and I'm sure there's a lot of science. Today, about 80% of my time is absorbed by general and individual teaching and by supporting research. Individual teaching means that I'm usually connected to courses, also visit the colleagues in their offices and help them doing their cases or help them out if something goes wrong with their cases and so on. Now, of course, I started my implantology with two-stage implants. There was nothing else at that time. At least I didn't know about bicortical screws. I didn't know about implantology. There was just a remark about blade implants. Are they justified to use and so on. I want to point out that in the phase when Lenny Linko started to work from probably 1956 to the middle of the 80s, there was nothing else. There were only polished implants. The implants were always in cortical contact. The colleagues worked in immediate loading protocols. Everybody tried to make roundhouse bridges, so this was implantology at that time. And only later, when companies like Nobel Biocare or Straumann appeared on the scene, then the big brainwash began. You're calling it big debate here, but I call it the big brainwash that was done to our profession. And suddenly we were taught not to use reliable corticals anymore, but to believe in surfaces. I mean, this was like the big stupidity that happened to our profession, and this is something that should be corrected. So as I said, I started my implantology with two-stage implants, and it was a successful business. I mean, it was not, it's not that I was too stupid to put two-stage, and then I came up with the idea of doing something else, so it worked, of course. But many patients did not have enough bone for these conventional implants, and many patients remained without treatment. Remained without treatment for me, or with not enough treatment, is if I cannot give teeth from 6 to 6. in both jaws. So if I have to send somebody away with a 5 to 5 or 4 to 5 or something like this, then I think this patient is undertreated. Something needs to be done. This is my personal opinion. I don't think that we should replace second and third molars, but we should give the patient the opportunity to have a first molar for a normal chewing function. This, of course, for the Engel class 1 skeleton relationship. Now, at that time when I started implantology, the bone augmentation was not yet invented. It was not available. There were some guys transplanting a little bit of bone from here to there and so on, but that colleagues were buying these powders and putting it into the jawbone. This was not yet invented, was not yet fashionable. The other problem was that implantology at that time was very expensive. So not only I couldn't treat patients to dentition 6 to 6, but also many patients remained untreated because they didn't have enough money. This is, of course, also a problem that we have to solve, and I think you have the same problem, even worse, in India, where large parts of the population are poor, and nevertheless it's your job, or it's our job as a dentist, to give them fixed teeth. So I kind of automatically decided to find better solutions, and solutions which would allow it to make teeth for everyone. Now, first of all, I was lucky that I had from 2002 on a production site for implants on hand. This was our own factory, so I was able to produce whatever I needed. So also the change in the design was done very quickly. If I needed parts, they were just available a few days later. So this was really very lucky. At that time also the medical device laws made it easy to change things, and the progress was going fast. So for the first 10 years of my dental implant practice, or with my basal implant practice, I worked only with the lateral basal implants, with these BOI, cortically anchored implants. And of course I worked in immediate loading protocols. I'm using this immediate loading protocol now 20 years, so I'm sure it definitely works. If you find cortical anchorage, of course. I don't think that an immediate loading protocol goes very well together with the surface of the implant, or with this surface story which we are being told. I have not seen so far that it's possible to make the bone grow within 1 or 2 days onto the implant, to mineralize within 1 or 2 days, and then to be able to catch the load for an immediate load protocol. I know that the companies like Nobel Biocare, they're moving a little bit into that direction. If you look at the instruction of the Nobel Active implant and how it is registered, for example, in the United States for the FDA registration, they allow this implant to be used if the torque is 45 Newton centimeter or more, which means in this case this is a compression screw. This has nothing to do anymore with the surface. So we should be a little bit clear about what the surface can do, what the design can do of the implant, and what our techniques of putting this implant in really can do. So what is the contribution of which part? So I think if everybody would keep things divided in your brain, if you're talking about immediate loading, late loading, osseointegration, and so on, then you would be very quickly clear about what things are doing, what the design is doing, and what our hands and the forces when we put the implant in is doing. And that, of course, in such cases when we are using the forces, when we are compressing the bone, it is completely irrelevant what kind of surface this implant has, because anyway there is no, let's say, active osseointegration. I personally think, this is my opinion, I personally think that this word osseointegration is the worst thing that could have happened to us, because osseointegration kind of brainwashed us completely, and we are looking for a thing that we don't need. And if it's enough if we fixate the implant, we shouldn't look so much after the question of osseointegration. Now, the second thing that was a bit lucky in my life, that I got into private contact with traumatologists. This widened my view, and it took me to a good road. If our implants would work like trauma implants, then we could use them in an immediate loading protocol, and there would be no bone augmentation necessary. We would then use the corticals, because this is what traumatologists are doing, and we don't need bone augmentation. So this was kind of very influential, this period, like 10, 12 years ago, where I was in contact with the AO. You may know this, the Arbeitsgemeinschaft Osteosynthesis in Switzerland. So these people deal with the question how to fix broken bone, how to apply, well, what to apply intramedullary nails or screws or plates and so on. Now I saw that it would not be necessary to change a lot of things in implants or in the design. So from the manufacturing point of view, we only added a few more lengths, a few more diameters. And the actual contribution of our group and also of myself to this movement of basal implantology or strategic implantology was to define methods or disciplines how to use these implants. So the definition of a clear method, which implant under which angle to insert into which part of the jawbone. This, in my view, is very, very important, and this will bring us to the future, because there are defined methods, there are defined target corticals which you should use, and if you do this, if you follow exactly the protocol, then you can work under an immediate load protocol. Today we have 14 such defined methods available, and I think the introduction of these methods were important for the success of strategic implantology and for the rising of strategic implantology, because now we can tell the practitioner exactly what to do in which area with the implant. You see, the two stages, they have a different philosophy. They use the first cortical and they use the spongious bone, and kind of their anatomy ends there. They don't have to know what is behind the spongious bone. The best bone, of course, is behind the spongious bone. The best bone is in the second cortical, because it is a resorption-free bone, and therefore it will be there forever. Now I'm happy to say that, especially in the last years, I see a lot of young colleagues who are carrying on this movement. I mean, I saw it's the big debate and the big boss coming. It's true that I'm influencing this a lot, but I'm happy to say that there are now doctors available for the patients, or doctors who are speaking on congresses, who I honestly think are better than I was. So my pupils are getting better than I ever was, and this is of course something that makes me very proud. I want to mention here a colleague from Russia, Dr. Oleg Dobrinin, because he added the possibility of navigated cavity preparation and implant insertion to strategic implantology. Now you might say, oh, this is so normal, we are all navigating and we all saw 3D, but what Mr. Dobrinin really made, he was using this navigation for a completely different purpose. The two stages, they're using navigation to make sure that the implant is, because the implant comes out with this emerging profile, so to make sure that the implant is in the right position so that they are going to have aesthetics. Of course, they also want to use the bone, but navigation, as far as I understand, was developed in order to get the position of the clinical part of the implant, of what we use, right, so that the tooth is going to be in the right position. Now, for the first time, then, somebody came, and he's using the navigation in order to find the second and the third cortical, and to find it not only with the drill, but also to find it with the implant, to reach it with the implant. And this, of course, makes the strategic implantology safe. It makes it 100% safe. And all these problems that the young colleagues are having when they start with placing implants, when they have to find the pterygoid plate, when they have to find the zygomatic bone, this is a complicated task, but with this way of guided cavity preparation and guided implant placement, it is very simple and very safe. And I'm convinced that this addition to our profession, to the strategic implantology, will make it much more easier to spread, the flame. So Mr. Dobrynin has showed to our profession that this all is a solvable problem. So the orientation, the 3D orientation in the jaw, is not anymore an objection. The third thing that I want to mention is that our implants are polished, like these implants were polished before, from 1956 to the middle of the 80s. Maybe you are aware that the term periimplantitis, this word periimplantitis, was appeared the first time in our scientific literature in the year 1984. So exactly at that time, when the profession switched from cortical engagement and from the polished implant to the rough surfaced implants, then also the word periimplantitis had to be invented, because this is what happened. This was the answer of the bone, was the answer of the body. And I'm happy to say that because we are now back to polished implants, we don't have this problem anymore. I'm happy to say that the polished implants, especially polished implants with a thin neck, are free of periimplantitis. And this is, of course, something that I'm happy to tell the patient also, because if the patient walks out with the implants and he goes back into his life, he and we can rest assured this problem will never decrease the quality of life, and it will also not endanger the implants. So this is something that I didn't expect to happen. This was not the plan, to develop a periimplantitis-free implant. We just see now it's like this. And then, of course, we started looking back into the textbooks in the 50s, 60s, 70s, and there was never anything written about periimplantitis. And today we understand that the surface story which we are being told made this problem. I also want to mention that the surgery for the strategic implant is very simple, because there are no bone augmentations necessary, and this procedure can be therefore performed in every clinic, even in a clinic with the lowest standard of equipment and the lowest standard of hygiene. Wherever hygiene or wherever the equipment allows to extract a tooth, you can also place this implant. You may use antibiotics. Probably some of you are using antibiotics. I'm not doing this. But you have to use, in any case, a powerful intraoral disinfectant like betadine, and then the procedure can be done safely. Of course, this procedure and the work with the strategic implant can be done also in high-class surgery rooms where you have these filtered airs and these capsulated people, all in green. But I'm sure, this is the experience of 20 years of working with polished implants, it is not necessary. That's also the reason why we can just extract teeth, also deeply periodontally involved teeth. We take them out, we just put the implants, because we are not worried of the spreading of infection. I saw, when preparing for this debate, I saw on the internet that some colleagues, mainly from the two-stage department, they are blaming us, for working risky and for, not being sterile enough and so on. I'm not saying that you should work without gloves and you should not take care of sterility. All I'm saying is that if in your clinic you are enough equipped, and you personally are enough equipped, and you work sterile enough to extract a tooth without killing the patient, endangering the health of this patient, then in the same clinic you can just place this implant. This is what I'm saying. Of course, you should take care of sterility and hygiene. Now, finally, the fifth point I want to mention is that the aesthetic outcome can be very beautiful, but the aesthetic outcome depends on dentist technician mainly, and it depends, of course, on the initial situation. I often get confronted in discussions that colleagues say, but this case, this is more beautiful. Now, in fact, if a patient has a lot of volume of bone and a lot of soft tissue and everything, in the right place, in the right height, and in the anterior-posterior position, then it's always easy to make aesthetics. If this bone and this volume, this support for the soft tissue and so on is not given, then the two stages usually have to give up. And they have to give up much earlier than we have to give up. Basically, we never give up. But the outcome may be different, and the outcome will be reached in a different way. So we have to train our dentist technician to work with the result of our surgery and then to give aesthetics. And for this, of course, you need trained dentist technicians, specifically trained dentist technicians, and you need a dental lab, which is also properly equipped. Just to give you an idea about my German clinic, the investment into the dentist part of this clinic, including the X-ray, so including the panoramic machine, was 40,000 euros. And at the same time, I had to invest 100,000 euros into the dental laboratory of this clinic. So this is the relationship which you will need. Because you think, you're the implantologist, and you're the big hero. No, nobody wants you. Nobody wants your implants. Even the patient doesn't want the implant. The patient wants the teeth. And there the big question starts. So who will make it? And sometimes in some clinics, I'm sure it's in India the same, this dentist technician part, the stupid appendix which nobody wants to our work is not regarded enough, and we don't take enough care of this. But this is really this thing that we sell. We sell the teeth. Nobody wants implants. I mean, they accept implants in the worst case, our patients, but they don't want to buy them, first thing. So I recommend that you think about such an investment. Maybe it's not necessary to invest 100,000, maybe 50,000 is enough. But please keep in mind that we are working in immediate loading protocols, which means we cannot drive through Mumbai 3 hours to the lab to get things done, because in the meantime the bone starts to remodel, because the bone doesn't care that the lab is so far away, and then suddenly we are out of the time limit for immediate loading. So I recommend that you keep the laboratory close by. The next point that I want to address is the question of science, scientific evidence. We are very happy to have Dr. Palker here, he is really the scientific guy in our group. He knows everything. He knows the citations. He knows everything. And of course, being a teacher also, I agree to the scientific concept. I agree to creating evidence. And it is definitely justified to spend time and resources on this matter, on this path to the truth, as it is called. The problem that I see, however, that it is so hard to see and to find real scientific work, to find real evidence in the dental field in general, and especially in dental implantology. I consider dental implantology the center of the red light district in dentistry. I mean, what happens in our field, this is really the worst. I mean, the biggest amount of lies is being told in our congresses. Now, what is true, what is wrong, why is the guy telling this, and so on, just to give you a few questions. We see, of course, thousands of articles in our journals, but are they worthwhile to read? Do they bring progress or news, or are they only repeating things which we already assume as true? Is it maybe only old wine in new bottles? Now, most of the things that we read in our journal definitely belongs into the fake news department, and they should go to the bin. One general problem of science is that scientists believe that they need some basic assumptions which are considered true. Now, like in a religion, some facts are simply taken as unchangeable truth by the believer. Now, for the believer, this is okay. You can believe what you want, and then this or that is your basic truth, and based on this, you build up all your beliefs. So that's just perfect. It also organizes the brain. In the real science, such truth, however, such unquestionable truth can never exist. Everything that we know, must be under question constantly. Almost nobody does this, of course, and if somebody from inside the university would do it, the tribe would throw him out. So everyone in science works with a few assumptions, or you can call it also citations, and builds out of this his or her own scientific structure. This is structuring of the brain, structuring of the department, and so on. And out of a number of such structures, they build a university, and after this, everyone only wants to stay at the feeding station with the lowest possible effort. Now that's the situation today in the universities. To conclude this, in my view, in the dental implant field, there is no science in science. Science became a special kind of religion, and we have a few high priests governing the rest of the tribe. Now, if you call me the big boss, I'm not in this business. I want to say this clear. Now, the way out of this, in my view, are the practitioners with a lot of experience. People who work hard on patients, who have their hands in the patient's mouth with blood on them every day. Because the practitioners have to perform their daily life on stage. They are the backbone of the profession. The backbone of our profession is the practitioner. It's not the university. And it's only the experience of the practitioner that counts. If we manage to create a theory out of this experience, then it's of course fine. We can start teaching even at the university, and we can be sure that this theory works because it comes out of experience. All theories which were developed from top down, these theories coming out of theory, they don't work usually. They only confuse and they disappear. And dental implantology is, believe me, it is full of stupid theories and stupid assumptions. And this is the big problem. This is the big problem in general in life, you know, that we are not trained to forget. We are all trained to learn, but we are not trained to forget. Because if we would be able to forget, we wouldn't need any psychiatrists or psychologists, and simply it would be easy. But unfortunately, stuff which is in our brain sticks there, and then it's very difficult to think around it. Now, luckily, we are educated in dental schools, and schools are schools, like the word says. So maybe the dental school was associated to some university, but we are lucky that we were trained as a practitioners, and we should keep on thinking in this direction. We should improve the abilities of our hands, of course, of our brain also. But the main thing that we need is manual skills. We need, of course, orientation, but we don't need so many theories, and we don't need so much scientific evidence. Not one patient comes to us because of our scientific knowledge. All the patients come to us because of our experience. Thank you very much for giving me the opportunity to lay these thoughts out. Thank you.